Hello, my name's Hatty Barthorp and I'm a Global Nutrition Advisor for GOAL. And I'm going to present a family MUAC cross-country evaluation which was conducted in Malawi, South Sudan and Ethiopia and funded through a grant from Electric Aid. MUAC stands for mid-upper arm circumference, and just to flag before we start, the term family MUAC has replaced the previously used term MUAC by mother to represent more accurately the role of all family members, especially fathers, highlighting the contributions they should be having to support the welfare of their family, including their children. So what is the family MUAC approach? It's a quick and easy method that families can use to identify children 6 to 59 months at home at risk of acute malnutrition. It can also be used to identify pregnant lactating women at risk using the same tape but just using different cutoffs. The simple tape is fastened around the circumference of the mid-upper arm, which measures the muscle and fat mass, which is used as an indicator of nutritional risk. Family members are trained on how to take an accurate MUAC measure to assess wasting, and also how to assess the children for kwashiorkor through the identification of bilateral pitting edema. Any child with a MUAC measure coding as red or with bilateral pitting edema indicates a risk of severe acute malnutrition, and they're referred immediately to a health facility with an outpatient therapeutic service. A measure coding as yellow indicates a risk of moderate acute malnutrition, and children are referred to a health facility with supplementary feeding services. Sometimes or often there is an absence of supplementary feeding programs, in which case families seek support from health outreach agents or health facilities to prevent further deterioration and try to understand improved home-based practices that can support an improvement in the child's condition. So why is it needed? Even in countries with relatively low global acute malnutrition rates, such as Malawi, for example, where it's around 3%, when we actually translate the statistic into actual lives, this still means around 80,000 children under 5 are affected by acute malnutrition. Many of these children either suffer in the community in silence, undiagnosed, or if they are identified, they arrive at medical facilities in a serious condition because their malnutrition is very often diagnosed late. Indeed, coverage assessments consistently show existing therapeutic programme coverage for CMAM services to be 50% or more often well under, meaning half or more of high-risk cases are simply not being diagnosed. So what's happening at present in most community settings is that either community health workers opportunistically check children for acute malnutrition in areas that they work, or there are periodic mass screenings which might occur every 3 or more commonly every 6 months. Opportunistic screening by health workers is known to have very limited coverage, and mass screenings happen so intermittently that many cases will simply be missed between cycles. However, as checks for kwashiorkor and the use of the MUAC tape is relatively simple, they can be easily learned by primary carers. So identifying a decline in nutritional status before serious malnutrition occurs. Identifying malnutrition earlier means that early treatment can be sought, which can vastly improve the health outcomes. So in 2018, GOAL trained a total of 6,515 family members across Malawi, South Sudan and Ethiopia through 315 pretty short 20 to 30 minute training sessions. So to standardise the training and the data collection, we developed a very simple training guide and an M&E toolkit. So the training guide focused on a welcome and the purpose of the session, an outline of what malnutrition was, how to recognise the first signs, the differences between wasting and kwashiorkor, the advantages of the family-based MUAC, and how and when to use it and what process to follow once the child's status had been identified. And the data collection focused on 3 main aspects. Firstly, the sensitivity of families' ability to accurately assess their children for acute malnutrition. Secondly, we looked at the impact on therapeutic care caseload, so the number and percentage of cases that would not have been detected through more formal established referral mechanisms. And lastly, we compared the cost of the 2 methods. So from these 6,513 families trained, there were 224 self-referrals made to health facilities between February and June 2018. With an 86% sensitivity, which means families correctly identifying positive cases, which was pretty good. In Malawi, TSFP admissions subsequently increased by 69%, and the OTP admissions increased by 25%. In South Sudan, there were only TSFP, Targeted Supplementary Feeding Programme, services available, and these admissions increased by 35% over and above what was achieved through the standard active case finding mechanisms that we traditionally see used by ministries. In Ethiopia, in the refugee camps where we trialled the approach, despite there being multiple points of contact with beneficiaries already, so community health workers were engaged in active case finding, there was monthly screening through SFPs, and there was quarterly mass screening as well, the family MUAC approach still identified 3.5% of cases that would otherwise have been missed, demonstrating A, the limitations of at best episodic formal screening, which has a limited reach, and B, that the family MUAC approach really does have a place even in well-resourced settings. So we also did a simple cost analysis to compare the cost of the family MUAC approach with the more traditional use of health extension worker screening. And in this evaluation, it was found to be 27% cheaper, with the family MUAC approach costing around 69 cents per person, compared with the community health worker screening, which cost around 95 cents per person. So what does this mean in more practical terms? In more traditional contexts, by shifting the responsibility of screening from the health workers to the caregivers, the approach has the potential to save money and very valuable time for community health workers. Overall, the financial benefits that we've just spoken about were considerable. Time saved by community health workers. There's a significant community empowerment element. There's early case detection supporting more efficient treatment. There's improved compliance and reduced treatment times, all of which reduce the burden on already strained public health services, demonstrating that the MUAC by Mother approach is a very valuable initiative. So next steps. Goals body of evidence merely adds to the already substantive body of evidence, much of which has been undertaken by ALIMA, demonstrating the considerable benefits of promoting the family MUAC approach. As such, GOAL are now promoting and supporting wider scale coverage of the approach in a number of country programmes where community-based services for acute malnutrition are available. Thank you.